Beyond silence. Rwanda's commitment to universal health coverage and the CRPD stands in stark contrast to lived experience of deaf patients. Despite progressive policies, systematic barriers within the health sector prevent deaf individuals from accessing quality care. The lack of Rwanda Sign Language services directly undermines NST2's social transformation pillar, which commits to strengthened health systems and inclusive development for persons with disabilities, thereby hindering progress toward universal health coverage and the principle of leaving no one behind. This brief focuses on these barriers and the economic imperative to remove them. Our methodology synthesizes data from rapid assessments, National Council of Persons with Disabilities (NCPD) reports, and global evidence on the cost of health exclusion, providing a comprehensive analysis of the current landscape and an actionable path forward. The depth of the systematic barrier in a granular analysis include the communication chasm, where fewer than 5% of healthcare facilities in Rwanda have staff proficient in Rwanda Sign Language, resulting in a significant communication gap. Deaf patients often rely on children or untrained family members as interpreters, leading to breaches of confidentiality and inaccurate information exchange. Detailed patient journeys reveal that note writing and gestures are inadequate substitutes for fluent communication, violating informed consent and patient safety protocols. This chasm not only impedes care, but also erodes trust between deaf patients and healthcare providers. The second is the knowledge gap among providers. Healthcare workers frequently lack training on deaf culture and autism, leading to ableist assumptions that deaf patients are too difficult to serve. This results in skipped consultations, particularly for SRHL services, where sensitive topics require clear communication. A case study of SRHL counseling reveals that deaf clients are often overlooked or rushed through appointments, exacerbating their vulnerability to preventable health issues. The third is inaccessible infrastructure and materials. Health facilities lack visual aids, Rwanda Sign Language video screens in waiting rooms, and accessible appointment systems. Even youth-friendly Yego corners, designed to serve vulnerable adolescents, fail to accommodate deaf youth. This institutional neglect reinforces exclusion and limits the effectiveness of otherwise well-designed health initiatives. The tangible and intangible costs of exclusion include public health costs, where the financial burden of misdiagnosis and communication errors encompasses costs associated with incorrect prescriptions, repeated visits, and unnecessary tests. Late presentations of disease, for example, treating late-stage cervical cancer is exponentially more costly than preventive screening and early intervention, generating significant savings for the CBHI schemes. These avoidable costs directly undermine NST2's social transformation priorities. They hinder the goals of reducing disease mortality through improving maternal and child health and compromise the achievement of universal health coverage, which depends on equitable access through schemes like the Community-Based Health Insurance (CBHI) for persons with disability. Additionally, the economic impact of avoided care, where deaf young people forego preventive services like vaccinations, family planning, and STI testing due to prior negative experiences, further exhibits public health challenges and increases long-term costs. The second, socioeconomic costs. Deaf individuals often cannot work due to preventable illness, reducing productivity and economic participation. The second, socioeconomic costs. Deaf individuals often cannot work due to preventable illness, reducing productivity and economic participation. The intergenerational cost of unplanned pregnancies and poor maternal health perpetuates cycles of poverty and inequality, affecting not only individuals but also families and communities. Third, legal and reputational costs. Non-compliance with the CRPD exposes Rwanda to potential litigation and undermines its reputation as a leader in health and development. The gap between policy and practice risks damaging international partnerships and donor confidence. A detailed blueprint for an integrated solution includes building a national corps of Rwanda Sign Language medical interpreters. Recruit candidates from the deaf community and hearing allies. Train them with a standardized curriculum in medical terminology, ethics, and confidentiality. Establish a mixed employment model, including full-time staff at national and referral hospitals, and a pooled on-call system for district health centers. Implement a national certification and licensing system to guarantee high-quality interpretation services. Second, mandatory disability inclusion and Rwanda Sign Language training for health workers. Co-designed with deaf stakeholders, this training will cover deaf culture, autism, and basic Rwanda Sign Language health phrases. It will be integrated into pre-service education for doctors and nurses and mandated as part of continuous professional development for existing staff. Accreditation will be linked to professional licensing to ensure compliance with relevant regulations. 3. Developing accessible health information. By producing a public library for Rwanda Sign Language video resources on key SRHL and general health topics, roll out pictogram-based health forms and visual communication boards for triage and consultations in every facility. Host videos on a dedicated Ministry of Health or Rwanda Biomedical Center online portal and install screens in waiting areas of youth-friendly corners and health centers. The compelling return on investment includes the health return on investment, where investing in Rwanda Sign Language integration will reduce the disease burden, maternal mortality, and STI transmission through earlier diagnosis and better adherence to treatment plans. These gains directly advance NST2's social transformation targets for reduced mortality and strengthened resilience health systems, delivering measurable progress on key national public health indicators and are in line with the World Health Organization's universal health coverage and health care for all. Economic return on investment. Savings will accrue from reduced hospitalizations, fewer repeated consultations, and a more productive workforce. The upfront costs of training and employment will be offset by long-term efficiencies. Third, social return on investment. Achieving CRPD compliance will enhance Rwanda's human rights record and empower a marginalized community. This empowerment aligns with NST2's focus on inclusivity development, fostering great social cohesion, and fulfilling the rights of persons with disabilities. In conclusion, we recommend the Ministry of Health and RBC establish a national Rwanda Sign Language unit with a dedicated budget and mandate. Additionally, we propose piloting interpreter program in 2 districts, one urban, one rural, within the next fiscal year and issuing a ministerial order mandating disability inclusion and basic Rwanda Sign Language training with completion linked to professional licensing for all health sector employees. This investment is essential for the success of the Health Sector Strategic Plan 5 and Rwanda's commitment to leaving no one behind. Success will be measured by a defined set of key performance indicators, KPIs, including the percentage of deaf patients reporting improved communication.